people. So hello, everyone. You are in the session of 130, Endocarditis and Joint Infections. We will go ahead and just start in just about 30 seconds. Okay, so good afternoon, everyone. Welcome to the 2022 Illinois Antimicrobial Summit. I'm Mona Van Canigan. I'm the Oral Health Section Chief at the Illinois Department of Public Health, and we are so happy to have Dr. Elliot Dept with us. Dr. Elliot received his master's degree in oral pathology and dental degree from the University of Illinois and completed his dental residency training at Ravenswood and University of Illinois hospitals. From 1989 to 2004, Dr. Dept was the director of the dental residency programs at Ravenswood and Illinois Masonic Medical Center. Okay, Dr. Dept received a master's degree in evidence-based healthcare from Oxford University. Dr. Dept is an adjunct associate professor of oral medicine at the University of Illinois and directs the Journal Club for Dental Residents at Illinois Masonic Medical Center. He teaches research methodology and biostatistics at the American Dental Association's Advanced Evidence-Based Dentistry Workshop. Dr. Dept has co-authored several ADA clinical practice guidelines and is an instructor at ADA's Evidence-Based Faculty Development workshops. Dr. Dept is the past chair of the ADA Council on Scientific Affairs and maintains a private practice in general dentistry. Dr. Dept, thank you so much for your presentation today at the session titled Endocarditis and Joint Infections, a very important topic here at the 2022 Summit on Antimicrobial Stewardship. Thank you so much.
Thank you. Thanks for the introduction and for the invitation. And I think the objectives today were to really have an understanding of clinical practice guidelines, first and foremost, why we have them, why we need them. And then we'll get into the guidelines on prosthetic joint infection and the ones on infective endocarditis. So probably most of you, and as far as questions go, I think maybe we can try to answer them during if we need to. Otherwise, we'll do questions at the end. Most of you have probably seen an evidence pyramid. I may not be the biggest fan of evidence pyramids because they're not all that scientific. And in fact, these two pyramids that hopefully you can see on your screen don't actually resonate with each other. But we do know as you climb up the ladder here that bias and confounding goes down. And if I were to ask you what should be here at the very top of the pyramid, which you don't see listed on either of these pyramids, would actually be clinical practice guidelines. So a little history on guidelines. 20 years ago, pretty much all we had were what's called GOBSAT guidelines, or affectionately called GOBSAT guidelines. GOBSAT stands for a bunch of good old boys sat around a table, and that's really how we got guidelines. You know, they just went around the table and said, what do you think? And what do you think? And what do you think? And then they put it all together and they got a guideline. So in the modern era, though, we have evidence-based guidelines. So we look for, or we actually do, a systematic review of the literature. So what is a guideline? Well, a guideline, it actually gives you two things. First of all, it's going to summarize the evidence on a particular topic, usually by doing a systematic review. The other thing it does is it provides a recommendation for or against. So in other words, doctor, we'd like you to start doing this activity, or doctor, we'd like you to stop doing this activity. So if we're going to pick an example of each, the example for would probably be sealants. Sealants have become kind of the example of when we have good evidence in clinical practice and dentistry But unfortunately, only about 40% of dentists and pediatric dentists use them routinely in practice. So the sealant guideline would say, we'd like you, doctor, to start using sealants in your clinical practice. And if we had to come up with an example of against, that would be for example, antibiotics for prosthetic joint infection. And why do we need guidelines? Guidelines have obviously been in the news a lot lately with COVID guidelines. So what we're trying to do, of course, is improve the quality and outcomes of care, reduce inappropriate variation in practice, which certainly happens in all disciplines of dentistry, probably no more common than in temporomandibular disorders. And hopefully we'll start coming out with guidelines for that to reduce variation in practice, promote efficient use of resources, and inform public policy. So that's kind of what a guideline looks like. We get an expert panel together, and we typically do a systematic review of the literature and come up with the guidelines, which I've already now described. What is a guideline and why do we have them? And of course, it should be differentiated from a protocol or a standard of care. I get a lot of questions on that. A protocol, if anybody here has worked in an operating room, for example, you can't just waltz into an operating room and kind of, rinse your hands off. You have a specific protocol of how to scrub, etc. So it's something that cannot be deviated from. A standard of care is really a legal or a courtroom definition of what is commonly done in practice in one's area. And of course, that is changing as well. So it's different. So a guideline is really, again, those two things. It's, doctor, here's the evidence on this particular topic. And from this evidence, doctor, we are making the following recommendation or recommendations for action or inaction. All right, so that's a little bit about guidelines, and now we'll talk about prosthetic joint infection. So I was involved in some of these activities. So in 2012, the ADA got together with the American Academy of Orthopedic Surgery, and we came up with a clinical practice guideline, and the guideline basically read as follows. The practitioner might consider discontinuing the practice of prescribing prophylactic antibiotics for patients with hip and knee prosthetic joint implants undergoing dental procedures. So if I were going to ask you, is this a well-worded guideline? Hopefully you would say no, because when you come up with a recommendation that says the practitioner might consider discontinuing, it's a little wishy-washy, and guidelines really should not be wishy-washy. And in fact, when we came out with this guideline, the switchboard at the ADA lit up pretty greatly, and so there were a lot of practitioners, a lot of dentists that had a lot of questions. And so at that time, I was also a member of the Council on Scientific Affairs at the ADA. And so what did we do? Well, we came up with a guideline as well, and it had basically the same single study that was included in the orthopedic one. We also found 3 more case control studies. And what did we come up with? We came up with this recommendation in general. For patients with prosthetic joint implants, prophylactic antibiotics are not recommended prior to dental procedures to prevent prosthetic joint infection. You see there this prepositional phrase at the beginning, in general. I was actually not wild about even putting in that prepositional phrase because it also kind of infers a little weakness in the recommendation. Unfortunately, I got outvoted, but that is the recommendation. And at least as far as we know, we've been tracking it. It seems like there is pretty good compliance in the dental community in terms of this particular guideline. This guideline and the one from the Orthopedic Society was really based on one rather large case control study. This is the Berbari study done at Mayo. And case control studies are actually really, really good for rare events, which fortunately prosthetic joint infection is a rare event. And basically the way the study worked is patients who were hospitalized with prosthetic joint infection, those would become cases. They were matched to controls. Matching can be done in different ways. And then we look back in time to see if there were differences in high and low risk dental procedures with and without antibiotics. And this was basically the summary table, table 5 from that particular study. And I direct you to the main result that was quoted in the abstract, an odds ratio of 0.8 with a confidence interval from 0.4 to 1.6. So as you can see from the p-value, this is not statistically significant. So in other words, there was no, we would conclude no association between high-risk dental procedure without antibiotics and prosthetic joint infection. A few notes about the topic. Do dental procedures produce bacteremia? The answer to that is yes. We have really good evidence that dental procedures do produce bacteremia. Does oral bacteremia cause PJI? Well, we really don't have much evidence to go on. Most of the early infections are staph. There are some late infections that are strep. In some cases, those bugs are from the oral cavity. But it is a bit of a stretch right now to say that those late infections are caused by dental procedures. Also, as you may know, the effects of antibiotics on bacteremia are actually unknown or unclear. We do believe that there's a reduction in bacteremia, but the actual effects are still really not known. And what we also know is that chewing, toothbrushing, activities of daily living also cause bacteremia. So it becomes difficult to measure were those cases, late cases, were they due to any sort of oral bug, number one? And if so, was it just having periodontal disease, poor oral hygiene, or was it associated with a particular dental procedure? A few other things that we can mention about PJI. Fortunately, it is rare, about 1 to 2% of joint replacements. As you may know, significant cost and morbidity. And they're usually early. So by far the not strep, that's the most common pathogen. So in the Berbari study, they actually went back and what did they do? They looked at some things, and I'll show you that in a moment. So we might say, well, what harm could it do to give antibiotics? I've had colleagues ask me this question. I'm sure this group is pretty familiar with both the individual and the population issues with antibiotics. So C. diff infections and anaphylaxis on an individual level, and of course, antibiotic resistance in a population level. Also, we do know that patients who do take the pre-med have gotten prosthetic joint infection. So that also is known. So that also raises some concern. And one of the things that I hope a lot of dental practitioners and others have to really look at is if there's really no known benefit, then we have to look at the other side of the ledger, which is harm. And I know a lot of practitioners say, well, I better give antibiotics for this prosthetic joint patient because if I don't, I could run into some legal jeopardy. But I think we have to start looking at it just the opposite. I gave antibiotics and the patient got sick or something along those lines instead of the original way. And one of the things that we did find from the Berbari study is that the risk factors actually were as follows. So some sort of perioperative problem like a wound dehiscence, a hematoma, and certainly a wound infection. Those were, of course, associated with PJI rather than dental procedures. So then the story kind of continued because the American Dental Association also again hooked up with the American Academy of Orthopedic Surgeons. And we did put together something called an appropriate use criteria, or an AUC. And that is something you may not be familiar with, but it's something that can be Googled up, and I'll tell you how to do that. So the guideline basically gives you the recommendation. So in general, antibiotics are not recommended for prosthetic joint infection. The appropriate use criteria basically answers the question, is there any scenario where we would recommend antibiotic prophylactics and or when the evidence is not detailed enough to apply the full range, to apply to the full range of patients in everyday practice? So the case control study that Berbari did obviously had a patient population, but could you extrapolate the results of that study to every single person that was likely to show up to your practice? So this is kind of how it looked like. If you're interested in finding it, you can just Google up appropriate use criteria for dental procedures, or you can enter the Academy of Orthopedic Surgeons. And so this was done back in 2016. And there you see at the bottom another way to find it. And it's basically an algorithm. So this is something that you, the practitioner, can actually enter on the website. So these are the things that you're going to see on the website. Immunocompromised status, not severely or severely. The next section is going to ask you about glycemic control. The third is going to ask you about any history of prosthetic joint infection. And then the fourth question is going to ask you about the timing. Is it less than a year or is it greater than a year? And this is what the algorithm actually looks like when you go into the actual screen itself. I'm just going to put my specs on. So here you can see that in this particular case, we've really answered no to all these questions. The procedure does not result in manipulation of gingival or soft tissue. The patient's not immunocompromised. They have no current diabetes diagnosis, no history of PJI, and it's been less than a year. So, and then the recommendation shows up to the right. And in this particular case, if you entered all this, you'd get the thing that you see at the upper right, the recommendation, which is it's rarely appropriate to prescribe antibiotics for this scenario. So then we went and we ran all the scenarios. I believe from this algorithm, there were 64 different ones, and only about 12 of them, it was appropriate to use antibiotics. So just to let you know, you'd have to be, if we back up for a second, you'd have to be doing a procedure that manipulated soft tissue. You'd have to be immunocompromised. You'd have to have an unknown AUC or an A1C above 8, possibly a history of PJI, and probably timing less than a year. So if you had that, you'd probably end up in this green box, and just a few of the different algorithms ended up in the green box. But you can see the vast majority are either rarely appropriate or maybe appropriate. So when you think about this green segment there, these are not patients that are really likely to show up to a private dental practice. These are really patients that would be showing up to a hospital dental facility. So again, it would be extremely unlikely for, let's say, a hygiene patient presenting to a dental practice to require antibiotic prophylaxis. All right, so that's the bit on PJI. Now we'll move on to infective endocarditis. I just thought I would put this up there. This came out in 2015, if anybody's interested, just the AHA statement on endocarditis. This is really more diagnosis, therapy, and management. And this is from the Journal of the American Dental Association. This is really the publication of the guidelines from 2007 in the ADA journal. So this guidelines were 2007, and this was published in the ADA journal in 2008. And I thought it would be kind of interesting to show a few tables from this particular paper, just to kind of show you the historical perspective on all this. So if we look at the top there, in 1957, for patients who needed pre-medication for endocarditis, you can see that this started 2 days before any sort of dental procedure was done. You were getting, 200,000 units. You might be getting an IM injection. So the units were started 4 days ahead of time. Then the IM injections were done a half to an hour before surgery. As we moved into the 1960s, it sort of continued up until, give or take, the late 70s or early 80s. So we were giving injectable IM antibiotics well into the 70s. And then as you can see there, starting in 84, now we switched it over to 2 grams of penicillin, and then we switched it over to amoxicillin. So you kind of see in terms of what we gave that there was a lot of high doses of penicillin, oftentimes injectable, given several days prior to surgery, dental surgery, or dental procedures. And this is also from that 2007 guideline. And if we go through these bullet points here, these should probably ring fairly familiar to you, and we'll see them again in a little bit. Infective endocarditis is much more likely to result from frequent exposure to random bacteremias associated with activities of daily living than from bacteremia caused by manipulation of dental or GI tract or GU tract. Prophylaxis may prevent an exceedingly small number of cases of IE, if any, in people who undergo a dental, GI tract, or GU tract procedure. The risk of antibiotic-associated adverse effects exceeds the benefit, if any, from prophylactic antibiotic therapy. So we can see that even back in 2007, these guidelines were at least fairly strong, I would say, in the force of the recommendation. And again, maintenance of optimal oral health and hygiene may reduce the incidence of bacteremia from daily activities, and is actually more important than perhaps the antibiotic prophylaxis for a dental procedure. So again, this is taken from the 2007. And here we have also from the 2007, the cardiac conditions that are associated with the highest risk of adverse outcomes from endocarditis, for which prophylaxis with a dental procedure is reasonable. Again, this should look familiar to many of you. Prosthetic valve or prosthetic material used for valve repair, history of endocarditis. You can see the congenital heart disease conditions that are listed there, and a cardiac transplant patient who develops a valvulopathy. So that is all from the 2007. And now we move to 2021. So this was the latest from the American Heart Association. And basically this was done to update the 2007 guidelines from the American Heart Association. So the conclusions, again, this only came out last year. And on these conclusions, the basis of the review of the evidence, there's really no recommended changes. There's a minor change to the 2007 guidelines. Again, they recommend prophylaxis only for categories of patients at the highest risk for adverse outcomes, while emphasizing the critical role of good oral health and regular access to dental care. They do say randomized control studies to determine whether antibiotic prophylaxis is effective are needed. That I might question the ability to even do randomized controlled trials, but we could certainly chat about that at the end if you're interested. Now, if you look at table 1 here, it very much looks pretty much like it did in 2007, although they're calling this major changes to the 2007. So, but again, they're saying IE is much more likely to be caused by transient bacteria from an oral source resulting from activities of daily living, i.e. chewing and toothbrushing, than from a dental procedure. Again, only an exceedingly small number of cases of IE could be prevented by antibiotic prophylaxis for a dental procedure, even if such prophylaxis is 100% effective, which we've talked about before, that we don't really know the effects for sure on bacteremia by antibiotics. Antibiotic prophylaxis was no longer recommended as a primary prophylaxis to prevent endocarditis in patients with underlying cardiac disease, even if it poses an underlying lifetime risk for acquisition of IE. And again, if antibiotics are effective in preventing a very small number, it should be recommended only for those patients with a very highest risk. And so that's essentially what we're doing today. And I just thought I would show you a couple more tables Again, not much has really changed from 2007. So if we look at table 3 on the left, that pretty much looks like it did before. The only difference is cardiac valve repair with a few other things, some prosthetics, as you can see, and left ventricular assist devices, commonly referred to as LVADs, have been added to the list. Obviously, a history of endocarditis and the congenital heart defects that you see listed continue to be recommended. As we move over to table 5, I don't know if you're aware, but one of the things that you see at the bottom is clindamycin was taken off the list last year. So clindamycin is no longer recommended for prophylaxis. It's been replaced by various cephalosporins. So that is different. So I thought I would talk a little bit about the studies for this. So let me back up for a moment. So if we go back to here, the American Heart Association statement from last year, a lot of these studies were referred to as interrupted time series studies. Some people call them before-after studies. So the way these studies generally work is these are actually called quasi-experimental because there's actually an intervention. So it's on a population base. So let's say, I think it was in the state of Minnesota, and I'll just pick a year, 2010. In 2010 in Minnesota, it was the state public health officials came out and said, no more antibiotic prophylaxis for infective endocarditis for these particular procedures. So that would then be the intervention, and then we would look at various health registries to see if there was any change in the incidence of endocarditis. So that's really how those studies work. And what I can tell you is the vast majority of these studies found that when antibiotic prophylaxis was no longer recommended, there really was very little movement of endocarditis in terms of incidence. One notable exception to that was in the UK, where they did find an uptick in endocarditis in that interrupted time series. However, it also was happening before the intervention occurred. So these studies are pretty good because they are interventional, but they are not, there's no randomization that really occurs with these studies. So one of the things that still can occur are, unfortunately, the presence of confounding. We can't really eliminate confounders from the bulk of these particular studies. But I did dig up a couple of relatively recent studies, dental procedures and the risk of endocarditis. These are two different studies. The first authors are different, although they have the same last name. And these are both case control, or I should say case crossover studies. So a case control, again, is where we basically wait, because endocarditis is not common, fortunately. We wait for somebody to develop endocarditis, they become a case, and in a case control study, we're looking back in time to see if the exposure was different, and the exposure in this case would be invasive dental procedures. In these particular studies, they were case crossover studies, which meant that the patients, instead of matching to a control person, they were actually matched with themselves. So then this becomes paired data. So this becomes, from a statistical standpoint, you get a little bit more bang for your buck. You get a little bit more power and precision. And you get it reduces a lot of the confounding because you don't have interpersonal differences. You just have intra, and certainly we're a lot more like ourselves than anybody else sitting next to us. So these studies I thought were very well done. And if you look at table 3, for both the unadjusted and the adjusted odds ratios, pretty much everything you see here is at the null value. So basically what they conclude from this is that when they looked at patients with infective endocarditis, and then they went back in time to see if there was any relationship between the endocarditis and having dental procedures at various points in time, they found no relationship. So this was one study out of Taiwan, which because of that particular country, 99% of patients were actually were able to be recruited. And this is the other study by a different author, same last name, but they also, again, found the same results. So in other words, they found no association. And if you go down the list of the odds ratio, even if they found a small statistical, if they found an association that was statistically significant, with odds ratios hovering around the null, they would not be clinically relevant to us as practitioners. From case control studies, you're actually looking for odds ratios taking a value of 4 or greater, and these are certainly nowhere near that. They're all hovering around the null value. And this is just the other group that they did. Again, you could look at the adjusted, happens to be a rate ratio, but again, all hovering around the null value. So again, what they conclude from this is that there's no association between antibiotic prophylaxis and infective endocarditis. So in Taiwan, they have stopped recommending antibiotic prophylaxis to prevent endocarditis. All right, so that brings me to my summary. And I think we're hopefully just seeing some trends here that when we go back and I show you that list from the 50s and 60s, certainly we used to give large doses of IM antibiotics, oral doses, and then IM doses starting the day of surgery. My second bullet point, I put in here, the null is strong. What does that mean? That means the null hypothesis is strong. So again, going back to scientific study, we start with the null hypothesis of there's no either difference between groups, or in this case, there's no association between exposure and outcome. And the null generally is strong, meaning we believe in the null and we do experiments to see if we can disprove it. And only when the probability of getting the observed effect is really low can we reject the null in favor of the stated alternative hypothesis. Even if you look back at some of our most popular medications, let's just say statins, for example, for lowering cholesterol, or statins for preventing heart disease or cardiovascular disease, oftentimes we have risk ratios that sit at 0.8, and in plain English, that means it reduces the risk of disease by about 20%. So even some of our best medicines, the magnitude of the effect is actually not that strong. So the null really is strong. And we certainly don't have evidence that would shove an association between dental procedures and either prosthetic joint infection or dental procedures and infective endocarditis to the point where it would be any sort of a strong recommendation at this point. So again, prosthetic joints, our third bullet point, generally don't need antibiotics. We do recommend them only in very small number of cases with patients who are very sick, probably not going to show up to a private dental practice, and have multiple comorbidities. My fourth bullet point I did put on there, ortho means orthopedic surgeons. And this is anecdotal because I see this in my practice. This is really not scientific, so I'm not really quoting any studies here. But I've certainly seen in my practice that the vast majority of orthopedic surgeons in our area, unfortunately, still recommend antibiotics, some for 2 years after prosthetic joint surgery, some for life. And of course, there's a lot of cognitive bias in my view here, because if you've ever seen photos or if you've ever seen clinically what a prosthetic joint infection looks like, there's a lot of morbidity and even mortality associated with them. So all orthopedic surgeons never want to see these things. So obviously they're biased towards giving antibiotics. So I think we still have a struggle in that arena because these guidelines are also from orthopedics themselves, but a lot of their practitioners, in my view, are not really on board with the recommendations. And my final bullet point, I apologize for that actually should read, might infective endocarditis patients, not valve patients, but IE patients, be treated similarly, or patients with valves. Are we marching down? Because when we used to think about cardiac illnesses or problems, many of them, as you know, used to be premedicated. So now that list has gotten smaller and smaller. And if more of these studies come out, like the 2 studies from Taiwan that I showed you, I think the one could question, are we eventually going to take most of our valve patients off the list? So that's it for me today. Certainly happy to entertain questions or comments.
Okay. Thank you, Dr. Abt. We do have one question. I'm going to see if I can post it here. Okay, so we're going to go ahead and accept questions. Go ahead and put them in the Q&A. We have one from Charles Rim. If evidence is not detailed enough for dental procedures causing PJI, why does ADA recommend the use of antibiotic prophylaxis? Is there any strong evidence/literature to show that dental procedures directly cause prosthetic joint infections?
So the answer to the second part would be no. We have no evidence to suggest that dental procedures cause prosthetic joint infection. And so from that appropriate use criteria, when we don't have evidence, essentially we do go back to the GOBSAT method, which is, where it's basically opinion-based. So we basically met with the orthopedics and the dentist. They got together and we looked at all those different cases, and we came up with a few scenarios where we would recommend it, but that is not based on evidence. That is based on opinion, okay? To the first part of the question, the ADA does not recommend antibiotics prophylactic antibiotics to prevent prosthetic joint infection. So I'm not sure where on the website if something was picked up, but if you go to ada.org and if you enter clinical practice guidelines, you will get our guideline from 2015, which appeared in the January issue in 2015 of the Journal of American Dental Association. But I'm not aware that the ADA has on their site that they do recommend antibiotics, unless this was something that was dug up from a previous iteration or something like that.
Another question, Raquel Mazer, not a question, but a comment. A vast majority of patients with prosthetic joints are asked to us to prophylactically antibiotic indefinitely, but by their own orthosurgeons. Any thoughts? So I think the question is, or the comment is, patients are asking medical providers about prophylaxis antibiotic indefinitely by their orthosurgeons. So the orthosurgeons are talking to patients, as I think that you mentioned, and then coming to possibly another provider saying, I need antibiotics indefinitely for a prosthetic joint. Can you just repeat that?
Happy to comment on that. If you look at the guideline, the 2015 guideline in the ADA journal or the guideline from the ADA website, along with the recommendation, and I think Aaron Kennedy talked this morning a little bit about, the ADA also has these laminated cards on various topics. So I think there may also be one on prosthetic joint infection. But along with the recommendation, where that recommendation again said, in general, prophylactic antibiotics are not recommended, there was a little blurb underneath it. And the blurb underneath it said that if your patient wants the antibiotics, it specifically said in our guideline that you should get it from the orthopedic surgeon. And they said that dentists should no longer write these prescriptions. So I'm in the private practice. I'm a full-time private practitioner of general dentistry. And so I can tell you in our practice that we no longer write these prescriptions. We tell our patients that the guidelines have changed, and if they insist on getting these prescriptions, they have to get them from their orthopedic surgeons. I can also tell you anecdotally that when I tell these patients what I just mentioned, they're actually very happy and very relieved to hear this. This is anecdotal, but most patients don't really like taking antibiotics. They don't like taking these pills. And as you know, even in a single dose, sometimes there's GI upset from them. So they're usually very happy to hear this, and they're happy to hear, and you can quote guidelines. You should quote guidelines in your practice. That's what guidelines are for. Again, they're to summarize evidence, but to make a recommendation. Those recommendations are for everyone. They're for us guys, providers, they're for policymakers, insurance companies, and they are certainly for patients. So I would strongly encourage any practitioner to mention these guidelines to their recipient audience, whether it's patients, dental students, dental residents, etc. So I hope I've answered that question, but please let me know if anything was unclear.
So you also mentioned the chairside quick sheet, and I put that link in the chat, Dr. Apt, as well as the ADA resources on antibiotic prophylaxis for both of the conditions you talked about today.
Right. Yeah, that was what it's called, the chairside guide. And I think there probably are chairside guides for most of the guidelines that the ADA has come out with.
Okay. Yeah, just making sure that people know that the Q&A is open now. So feel free to write the question in the chat, and then we will address them as they come in. We might be ending early. So I don't give people maybe another, okay, let's see. Okay, here's a comment from Raquel Mazer again. Elliot, thank you for the comments. I have adopted the practice of explaining to my patients that the surgeon will order the antibiotic or the prescription. Appreciated. Okay. Let's see. I don't see any more questions or comments. We can give people one more minute. I want to thank you all for attending. It looks like we've had 22 attendees, including you, the presenter, Dr. Abt. And then as we're waiting for some final questions as they come in, I want to invite you to the two other oral health related topics that are scheduled for today. And one starts at 2:35, and that's by Dr. Michael Durkin, Antimicrobial Stewardship for Dentists. And then the next session at 3:45, Management of Acute Oral Infections in Medical Settings. Okay, well, I want to thank you, Dr. Abt, for taking the time from your private office, your private care for patients, in helping us understand these two very important topics. Thank you again, and appreciate your expertise and sharing the insights that you have.
Thanks again, Dr. Van Kanagan, and thanks for having me. Appreciate it.
Okay, bye.
Bye-bye now.